Sorry.
I was only had a PC. That was more of a vamp, because we're wanting to consistently start our presentation on the hour so that people who are logging in on YouTube as we're trying to build that can have an expectation of us reliably getting started. So you have a few more minutes. Think about what you're thankful for. If you didn't share, you can keep sharing in the chat. But I'm really excited to have one of those lovely people who, as I was saying, makes the work that we do together so pleasant and so joyful, presenting for us today, and that is Marcos Campos. So I'll let him introduce himself and the presentation he's going to give today, which is about alcohol use during pregnancy. So you're welcome to take it away, Marcos.
Okay, thank you so much. I'm Marcos Campos. I'm physician in Brazil and collaborator to GEMINI. I will share my screen.
Go ahead.
Yep.
So today we will discuss about this paper. It's a proposal paper that we would like to write, and the same line of the menos alcohol. It's a big project, very similar to the PPK, and we are trying to implement at the Amazon region and here in São Luís also. So the proposal paper, it's alcohol use during pregnancy implied poor perinatal outcomes, evidence from a Brazilian cohort study. So this is a picture of the city São Luís, where the place will be the place of the study, and this is my city. So why this issue is important? Sorry. The alcohol use is a public health problem, as we know. And during the pregnancy, we have this statistic that 1 in 10 women consume alcohol during the pregnancy. And the health organization said no units of alcohol is safe to use during the pregnancy because it impacted a higher stillbirth rate and horse perinatal outcome as low birth weight, prematurity, and birth defect. We have a syndrome that is called fetal alcohol syndrome. It's a hard syndrome, but is related to use of the alcohol during pregnancy. But not only that syndrome, we have other kind of outcomes that is very severe. And the place of the study is São Luís, is here in the map. And we thought to perform here because most part of the evidence related to perinatal outcomes during the intrauterine alcohol exposure comes from high-income countries. Few study was performed in low and middle-income countries. So São Luís is located in the poorest region in Brazil, at the northeast part, and is a city that there is an estimated prevalence of alcohol use during pregnancy in 14.5% higher than the global prevalence that is estimated less than 10% during the pregnancy among the mothers. So here we have a higher consume of alcohol. So the aim of this proposal paper will be to describe the alcohol use prevalence among women in birth cohort in São Luís, Brazil, and to estimate the risk of adverse perinatal outcomes in alcohol users at the different stages of pregnancy and birth cohort in the city of São Luís. So we based it in a population-based cohort of births conducted on a sample of mothers and children evaluated at birth time. This is part of a large study that calls etiological factors of preterm birth and consequence of perinatal factors on children's health. This is a big cohort involving two cities in Brazil, Ribeirão Preto, located in São Paulo, and São Luís, and part of three big cohorts of birth that performed in Brazil. That cohort happened in three moments during 2010 and 2011, where the mother and the baby was evaluated. After this, with 1 year of age, the children was evaluated again, and with 13, it's a scholar time, a scholar age. I don't know how to translate this, and the children was evaluated again after the COVID. So we will focus on the first step of the cohort, where for maternities hospital in São Luís, with the highest number of births happens. So the four maternities were selected to take a probability sample, a representative sample of all the births in São Luís. We had estimated of 5,000 births by year in São Luís. And we selected one in each three births were selected. So we had a final sample of 5,000 children. This is all the numbers of the births that happens in 2010, 21,000. And after the exclusions or refusal, we had the number of the interviews performed. So what was collected at that time? The demographic and socioeconomic data, characteristics of pregnancy, health problems during childbirth, some characteristics of the newborn, like weight, length, and the head circumference, and related the alcohol use during the pregnancy was collected information of the what kind of alcohol beverage, what type of the alcohol, which trimester of the pregnancy the use happens, and some questions like, did you drink beer during pregnancy? Did you drink wine during pregnancy? During pregnancy, did you have any other type of drink, such as whiskey, vodka, gin, rum? That was the question. So some results. The mothers were very young. The median was 24 years. The most of the sample was the sex, male sex, the life-born, and few had any type of congenital defect during the birth. And the prevalence of smoking during pregnancy is very low, only 4%. This is different of the prevalence in Brazil. The prevalence in Brazil is higher than 4%. Here is one place that no one smoke, not no one, but few people smoke here. But the alcohol consumption was 13%. Can you hear me? I think
Yes.
yeah, okay. My headphone was discharged. So about the alcohol frequency used by week, we have estimated less than 1 day by week of the use. And regarding the standard unit, the standard unit represents 10 grams of pure alcohol. So depends of the kind of the beverage. We have 0.13 the standard unity per day in the first trimester, and that was getting low during all the trimesters. The first trimesters, we have more use comparing to older trimesters. And regarding the type of the drink, we have the most part of the consumption was with beer, but we have also wine and distillated. And the first trimester we can see represent the most part, the most moment of the use, and after this, we have less consumption. And regarding the dose per day in each trimester, here is only for the whole consumers, we have less than 2 standard unit of alcohol by day in all the trimesters. And here is the number of the standard drink unity by week. And we can see who consume 1 to 5 standard drink by week. Here is older in the first trimester. We have a higher concentrate for who use less than 5 standard unit of alcohol by week. But of course, we have important concentration of who use more than 10 standard unit of by week. And this is stable during all the trimesters, first trimester, second trimester, and third trimester. Represent always less than 5 standard unit of alcohol, but a higher concentrate in all trimester. Sorry for the table. I was adjusted this right now, but here is represent just the first trimester, comparing the life-born weight, congenital defect, gestational age by week, and the prematurity classifying as a categorical variable like full-term birth and preterm birth, and comparing the use or not use of alcohol during the first trimester. And by the statistic, we don't see any difference in the group, but we can see a tendency of the who use has less life-born weight and maybe less gestational age, and more more concentrate of the preterm birth also. Of course, the second step is separated by the alcohol use during the week, not only yes or no use, but the how is the use by the week, for example. So the next step also will involve to select the variables to use during the model using directed acycle graphic, the DAG, to select the confounded variable, because we have, of course, a lot of variable involving the low birth weight, the prematurity, and we need selected all the confounded variables. And we have a database with a lot of information, such as sociodemographic or congenital problems, health problems during the pregnancy, health problems of the mother, and we needed to select that confounders and control here in our model. This is the next step of the study. This is just to show the potentially that we have at the database. So thank you so much. Obrigado.
Marcos?
Hi.
Questions or comments?
Yeah, Marcos, can you go back to the graph with the pattern of use? Yes. So let me just understand this graph a little bit. So this is the number of standard drinks across all kinds of drinks reported per week.
Yeah, by week.
by week. And so what you're telling me on this graph is that there's 40% of binge drinking use in average.
There's nothing here that's can tell you it's binge drinking.
Well, 6
But
drinks per week.
That's a standard drink per week. That doesn't mean one event.
But it's
It could be one drink a
high
day
risk
for 6 days. That's not binge drinking.
use, but it's high risk use,
That's
which is greater than the
Okay.
number of drinks per
So
week.
it's not binge drinking events, but okay,
But it could be at risk
Yeah.
use.
okay.
Because
So
it's for women, I think it is 10. I'd have to look, I don't remember.
I think it's more than.
and it kind of is consistent. So go to the next one.
No more than 7 drinks per week is the recommendation from NIAAA.
Go to the next one. Yeah.
Unpregnant women.
For women,
So
in
it's-
general, forget pregnancy, yeah.
It's the same. Go to the next one. Yeah, it's pretty consistent when you look at that. It might be
Oh, this
interesting.
is just for the third trimester. Sorry, what was the other one? For all?
Second and the first.
Yeah, this is just like looking at the gestational. It would be very interesting, Marcus, to have one of those graphs that show the variation over time to see how many people
Yep.
are in a group and continuing that group. I'm also thinking that this would be a great alcohol profile change study at another time. So anybody who wants to do some latent profiling, just look at the patterns of drinking and how one person would be likely to change from one class of pattern of drinking to another at a different period, and what are the potential predictors of that change. For those that reduce, for those that improve or increase. That might be
Yeah.
interesting as well. Just very striking. So it also points me back to, Marcos, to the other table where you are comparing the different pregnancy outcomes related to any drinking, if I'm understanding right. We might need to look at that table regarding harmful drinking, if we are able to estimate that level, or just try to put that analysis towards something that gives a more risky drinking.
Yeah. Can you clarify, Marcos? The table was just any drinking versus no drinking, right?
Yeah,
So yeah, I agree with
the
Joao.
table here, yeah.
If we wanted to cut off, for example, the way you have in those figures, where less than 6 drinks per week, even though we know that any level could be dangerous, that might give us some more effects, because it's really surprising to me, this table not getting significant results for such a large sample. But maybe it's
Only
what
500.
Joao is getting at,
Yeah, it's only 500 per use.
who do drink. Yeah, but still, that's a pretty big sample.
Yeah. Well, also, it's a continuous variable. So it might be interesting to look at this from a continuous perspective as well.
That's true.
Maybe categorize it on the,
Yeah,
Rather than
Yeah.
yes, no.
Versus daughter, yeah.
yeah, because every time you categorize variable, you're missing information. So either you're very true, you're very clear on what that categorization is for, or you're just creating a cutoff that could not mean anything.
Yeah.
So and there's this discussion around, yeah, and IAAA says 5 drinks is okay, while WHO says no drinks is okay.
Right.
And then there's a discussion around what is okay for pregnant women. Is there any guidance to say 1 drink is okay, 3 drinks is okay? If we don't have a very clear notion, it might be just interesting to look at this continuously. Is there a point where the amount of drinks then starts to be related to reduction in weight, increase in the facts?
Maybe there's a
Yeah,
hinge, like a
yeah.
inflection point.
Yeah. Exactly. So we might want to do a little bit more exploration on this descriptively before we jump into the DAG, because I think it also helps us identify how are we modeling alcohol? Are we modeling alcohol as a continuous variable or as a dichotomous variable? That part for me is not clear yet.
Yeah, I think those are all really good points. I wanted to highlight a couple of pieces of conversation in the chat. And Marcos, maybe you can speak to those for this data. I'm not sure. Rosalia and I think Charla raised points about is there data on whether these people knew they were pregnant or not? And Rosalia points out, is that why the first trimester has the highest drinking level, which is a pretty good hypothesis?
Sure.
Because in the first trimester, they're less likely to know that they're pregnant. Or she points out in a separate comment, or it's unplanned pregnancy, which you know, you're more likely not to know. Yeah, can you say something about that, Marcos?
Yeah, I can't say, but at the database, we have that question, if it is unplanned or planned pregnancy. And with time, the mother figure out the pregnancy. We have that information. I don't have it here, but we have at the database.
I think that would be an interesting thing to stratify by,
Yeah.
in my opinion, especially for that first trimester.
So it's a good confounder.
Mhm.
I think that's the kind of discussion you wanna have, Marcos. Whenever you have the DAG built, it might be interesting to have another round of this to show the DAG and see if people have what additional variables or additional roles of variables within the DAG to talk through.
Yeah. I began the DAG, but there is a lot of information because if you see all the variables that could imply at low birth weight, it's a lot, a lot. And we have that information at the database. I don't know if we use a latency variable or something like that.
Yeah. Well, let's start small. Build
Okay.
build the most simple DAG possible. And then let's enhance the DAG as we get feedback on it. It might be a lot easier than if you try to do a very comprehensive one to trim down.
Okay.
I just want to add what's terrifying for me is that this is a retrospective self-reporting. And we know that people report far less than they actually use. So that's what's kind of terrifying here is that those numbers are probably higher.
Yeah.
Right, there was somebody at the ACSTEM conference that we recently went to was kind of making a cheeky joke that like, when you ask your patients, you know, how much they had been drinking before they ended up in the emergency department, they always say 2. It's never 1, it's never more than 2. But it's kind of like one of those where it's like, they know that it's stigmatized, especially if they know they're pregnant. So they're never, you know, there is definitely some bias there, which is
Okay.
And
William asked about the congenital defect because we have 8 children here that at the group of alcohol use, and if the congenital defect was related to alcohol use, like fetal alcohol syndrome. I don't have this information. I don't have this data at the database, but I think it's possible to rescue at the hospital record. I think that there is the information in some place because at the questionnaire was writing information, and I don't have this at the database, but I think it's interesting to take some information about this more detail.
Any other questions or comments? Particularly, love to hear from any of our other maternal and child health researchers. Anna Perna puts in the chat, I wonder what are the reasons that cause women to consume alcohol during pregnancy, which is actually a crucial time for both the mother and the child. Of course, that's the big curiosity underlying the data, right?
Yeah, some of our prior work in Tanzania has found that those that continue to drink during pregnancy are the ones that were drinking before pregnancy, right? That kind of makes sense. You just haven't stopped yet. But as also, I think Rosalia pointed it out in the chat as well. This means we have to start thinking about women as potentially pregnant constantly. And that we need to bring that into not only our healthcare, but our prevention work.
That's how a lot of the public health approach has taken it in the States and, you know, around the world is, you know, that's why we fortify our breads and our milk and our products, because we know that like women aren't gonna, it's gonna be a little too late before they start taking the folic acid, right? Let's put it in the food system is the thinking, because it's low risk and it's gonna have a huge population benefit. So we can think of that for our alcohol messaging too, especially because we have the data to show you that, you know, alcohol is not healthy for anyone at any amount, no matter their pregnancy status. And then I see Charlotte said, there's some cultures that are okay with small amounts of alcohol. You know, so you'd be going against a norm by talking about abstinence, which goes to Drow's data point, like if we're talking about continuous versus binary data, you know, think about too, what would our goal or our intervention be in the future? Would our reasonable goal be abstinence? I mean, some would say yes, especially for pregnancy, but in certain cultures, and if the data support it, maybe getting down to 1 drink a week would be enough to prevent bad outcomes.
Anything along the spectrum of less is better.
Any final thoughts from you, Marcos, or last call for questions and comments?
So Marcos, just to speak to the innovation in this work, we were just at Inebria last week in Barcelona, and there was a lot of people that were really very interested in thinking about brief interventions for women who are pregnant, how it's not been implemented, how we have a lot of space to grow in this area, and there's a lot of science that needs to be built around here. So great job on really important work. It'll be very impactful to see really, goodness, 15% of women are still drinking and at really high rates. So really nicely done. Beautiful, beautiful work.
Okay, thank you so much.